Assalamu alaikum, the clinical day. First scenario, Mrs. Nadia Adam, 35 years old, presented with abdominal pain for 1 month duration. Please sit with her, examine, and address her concerns. If you're ready, Dr. Mahi, we can start. Dr. Muhammad also?
Yes.
Yes, here you go.
Hello, Dr. I'm Dr. Ismail, the Senior Health Officer of the GI clinic today. Am I talking to Mrs. Nadia, and you are 35 years of age?
Yes, it is. Yes, it's Nadia.
Nice to meet you, Mrs. Nadia.
Nice to meet you again, doctor.
Today we will discuss your health issue, and I will examine you and address your concern. Is that okay with you?
Yes, fine.
First, may I ask you what brought you to the hospital today?
Doctor, I was complaining of my tummy pain since 4 weeks. It was intermittent, coming and going. But recently, in around 1 week, it's persistent, and I am too much bothered with this pain. I visited emergency department. There was nothing significant with me, but still I am complaining of pain, apart from all those medications that I have received, but still the pain is there.
I'm sorry for that, Mrs. Nadia. May I ask you, where is the site of the pain exactly?
The site of pain, usually all over the abdomen.
All over the abdomen.
Yes.
If we score it from 0 to 10, 0 is no pain and 10 is severe, how much you can give score?
It's around 7 over 10.
I'm sorry for that. Do you need a painkiller now?
I have already pain medication, but I am worried about what's going on with me. I need to see what's going on, and I need you to diagnose my situation.
I'm sorry for that, Mrs. Nadia. We will try to help you. May I ask you, what is the nature of this pain? It is colic in nature or dull aching or stabbing pain?
Non-specific, doctor. There is no specific nature, but it's like occasionally there is dull ache, dull, severe pain. Yes.
Okay, it radiates to which side of the tummy?
To the back and usually to my right shoulder.
To the back and to the right shoulder.
Mm.
May I ask you, do you think anything make it better, like fasting or eating special type of food?
No, no.
What make it worse?
What makes it worse is
Anything
usually
make it worse, Mrs. Nadia?
we can say after heavy lunch or during movement, when I was moving my tummy, there's a pain. Yes.
When you walk, it pain come?
Not so much, no.
So it is aggravated only by walking?
And heavy lunch, yes. Heavy food intake.
Any
Yes,
specific type of food aggravate it? Any specific type, fatty
yes,
food more or
fatty, yes. Burger and kebab, yes.
Okay. May I ask you, in addition to this tummy pain, is there any feeling sick or throwing up?
Yes, occasionally, but not so much. Yes, I can feel. Yeah, I am nauseated most
Any
of the
change
time.
in you? Any change in your bowel habit?
No, no.
No change. There is no hard
There was
motion or loose
there was
motion.
2 days history of diarrhea, but now there is no more loose motion.
What is the cause of this loose motion?
I am not sure. I don't know. It's the
It
first
was
time.
infection, or what is the type of this loose motion? It was bulky, offensive, or it is watery?
Watery, watery.
Watery. No
Yes.
blood mixed, no mix with blood,
I haven't noticed any blood. No.
huh? Not mixed with blood.
No.
Uh, I ask you, this tummy pain, it awake you from sleep by night?
Yes, occasionally. Not so much, but I can wake up because of pain, especially in the morning,
Mm.
early morning.
Early morning.
Ah,
Mm.
yes.
Any change in your weight, Mrs. Nadia?
Not specific, no. I cannot appreciate.
No change in weight.
No.
Any change in your appetite?
Yes, yes, I cannot eat because of all this pain.
Mm. Any type of food or all the food you don't want it to eat?
I get afraid of from eating usually. I'm just eating some yeah, picky eater. Usually it's a picky eater because of this problem.
What type? What type of food?
Picky eater. Yeah, I'm just picking some specific types. I cannot
Mm.
eat freely. Yeah,
Okay. Do you feel any raise of your body temperature?
I can see. Yes, I feel I have some raised temperature. Yes.
Uh, did you check it? How much? Measure
One
it?
time, yes, one time I was checked, and usually it's around 38, something like this. Yes,
Okay. Hmm. Any night sweets?
I can feel. Yes.
Hmm. Do you feel this night sweating, it wets your clothes, severe or drenching
Not, no,
sweating
no,
or
not to that much. No,
hmm. Any specific time of this sweating by night only or all the time? Or
all of the time, but usually I feel the sweating at night. Yes.
hmm. Do you feel any lumps or bumps in your body?
No,
Hmm. Anyone told you that you are pale more than before?
no, my face now is ruddy. I don't know what's going on. Red.
Hmm. Do
Yes.
you notice that a change in your skin or your eye color?
No, the eye color change. No, the skin yes changed over my face.
It changed to which color?
Yeah, purple, sometime red.
Purple?
Yes, purple, red, something like this.
Hmm. May I ask you, Miss Nadia, do you have any past medical history I should be aware of?
No specific past medical doctor, but since
Hmm.
long time I am complaining of fatigue.
Fatigue,
Yes, I am tired all of the
hmm.
time.
Tiredness. You feel tiredness for how long?
The tiredness, it's about 6 months.
6 months. All the time or specific time of the day,
No
early
specific
morning,
time.
at the end of the
No,
day?
I can feel tiredness throughout all these months
Hmm.
with no
And
variation in day or night.
uh, mm, do you have any itching?
No itching, no.
Mm. Any surgical history?
No.
Any blood transfusion before?
But I have done one, 2 times curtage.
What is cortege?
Curtage. Dilatation and
Cortege?
curtage.
Huh? Dilatation of what?
Dilatation and DNC operation.
Ah,
Gynae, yeah, woman
yes.
operation.
Yes, yes, yes. But
For,
no blood
for miscarriage.
no blood transfusion.
No, I didn't receive any blood. No.
What about your mood, Miss Mona? It is
What,
okay or
what was what was your
low?
question?
Your
What was
mood?
it? Mood, low mood, doctor. I have low mood.
Mhm. Does this mood affect your gut habit?
Gut habit. I am not sure of that. But I have low mood.
Uh,
Yes.
okay. May I ask you previous question, Mrs. Mona?
Yeah, definitely.
Uh, okay. What about your period
My period
volume?
is irregular.
Hmm?
Irregular, not regular.
Ir- Hmm. And what is the amount?
Sometimes very heavy. Yeah. Yeah. Too much.
Do you have any weather preference?
No weather preference. No.
Miscarriage before?
2 times.
2 times. At the age of what? Pregnancy?
31 and 33. You mean the
31.
during the pregnancy time? Okay, it was very early, too small. The baby was too small.
Okay. Do you have any mouth sore?
No,
Any skin rash on sun exposure?
I can imagine. My face rash aggravated with sun exposure.
Okay. May I examine you, Mrs. Mona?
Yes,
Mrs.
yes,
Nadia?
yes. You can.
I will see the hand for any change in the color, nail changes, pulse, any abnormality in that.
Tachycardia, pulse rate around 110,
Mm,
shiny skin,
mm.
and
Blood pressure,
pressure is normal, 110/70.
any tight skin,
No tight skin, but shiny. I think it's swollen.
any deformity,
No deformity.
sclerodactyly,
No,
sclerodactyly.
no, no,
Mm. There
no
is any
deformity.
sclerodactyly. There is any deformity in the fingers.
No deformity, doctor.
Hello.
Do you hear me, doctor?
Uh,
Sorry.
if you exposed it to cold, there is any change in the fingers or the hand?
Yes, I
Pain?
feel this. Yes, the color changed to pale or white color,
Mm.
sometimes blue. Yes, during cold exposure.
Mm. So there is tight skin or no?
No tight
While I'm
skin.
doing bench,
No, no,
no
no
tight
tight
skin.
skin.
Any buckling of the around the mouth?
No,
Any pinched nose?
no,
Any difficulty swallowing, Mrs. Nadia?
no.
Any shortness of breathing?
Occasionally on exertion. You mean the finding?
Difficulty swallowing. Difficulty swallowing.
No difficulty in swallowing. No, it's normal.
Mhm. There- any subcutaneous calcinosis or anything examination of the upper limb?
My hand is totally normal, apart from shiny skin and high pulse rate.
Okay, okay, okay. May I ask you, Mrs. Nadia? Hello?
Hello, doctor. I'm hearing you.
Do you drink alcohol?
No,
2 minutes left.
Do you smoke?
no.
Okay, okay, Mrs. Nadia. Uh,
But
may I
doctor,
ask you?
I have
Yes,
abdominal pain. You are not examining my tummy?
yes, I will examine your tummy. Yes, yes. Um, I will, any pain, tell me. I will try to be gentle with you. I will do superficial palpation to see any initiation of pain
I
or
have
tenderness.
pain. I have pain in all over my belly.
Mhm. And the right upper tummy also still pain. There is there.
Yeah, the pressure and heaviness more in the right upper.
It radiates to the right shoulder.
Yes.
Okay, okay. But no organ, no liver, no spleen.
No, I have some abdominal distension.
Okay. What is your concern, Mrs. Nadia?
I need diagnosis. What's going on with me?
Uh, I appreciate your concern, Mrs. Nadia. There's some possibilities in my mind, but the most one of them, I'm thinking about anything related to the gallbladder, like what is named as ascending cholangitis, soreness in your gland that secretes bile to the. So I will do for you some blood test and the imaging sonar for the tummy. Then I will, after release of these investigations, I will sit with you and update you about the diagnosis. Okay?
Okay. Okay.
Do you have any other concern?
I have no more concern. No.
What? What you?
I have no more concern. No.
Okay, okay. Thank
Okay,
you, Mrs.
time is up. Dr. Mohi, please check your mic. There is some interruption in the sound. Just to check it before going to the examiner questions. Yes, we can start now.
Okay. خلاص. Okay.
Are you
Dr. Muhammad.
using a mic or a speaker? Because still there is some echo in your sound.
Really؟ طب ممكن اخرج وادخل تاني؟
If you are using mic, you can disconnect, or disconnect and reconnect the mic itself, or use a speaker if you are using the phone.
طيب. الصوت تمام كده؟
Uh, okay, continue, carry on.
Okay, okay.
Start, Dr. Muhammad, sir.
Yes.
Yes,
Start
Dr.
the examiner question, yes.
What's your diagnosis, Dr. Muhi? Hello.
There is gallbladder stone, chronic cholecystitis like this, with infection on top of this cholecystitis, possibly calcular or non-calcular cholecystitis.
What else?
I think also another thing, I think about Budd-Chiari syndrome, because patient possibly this is antiphospholipid syndrome, miscarriage, recurrent blood clot. So maybe this is, but there is no any evidence of decompensated liver. This patient for 1 month now, but maybe this is subacute like this.
And what is the cause of this generalized abdominal pain? And I have already some. You didn't examine my leg because also there is edema, pitting leg edema bilaterally. And I have photosensitive skin rash. Yes. What could be the cause of all these presentation apart from antiphospholipid?
Possibly this is systemic lupus erythematosus.
Yes. Yes, you are right.
Yes. Systemic lupus erythematosus with
Yes.
secondary antiphospholipid syndrome.
Yes, combined SLE and antiphospholipid antibody syndrome.
And the cause of this abdominal pain is?
The cause of abdominal pain was Budd-Chiari syndrome.
Dr. Muhammad, talk with him as examiner, so give him the option and the question of differential, and he might approach. Yeah.
Okay.
Don't help him, okay?
Okay. Okay. What could be the cause of this abdominal pain?
So this is blood clot, Budd-Chiari syndrome.
What else? SLE makes abdominal pain through what mechanism? Cause of abdominal pain in SLE?
In SLE generalized cause abdominal pain. Many causes can cause abdominal pain by systemic lupus, but in this case, this patient has secondary antiphospholipid syndrome, so possibly this is recurrent blood clot.
Okay, SLE makes colitis, makes serositis, also makes thrombosis by itself. Yes, the causes of abdominal pain. What are the lines of investigation you have to do?
There is general investigations, specific investigations, and the bedside test. Bedside test now we will do ultrasound abdomen with Doppler on the hepatic vein to see the enlarged liver, should be enlarged tender liver, yes, and should be the Doppler low flow or no flow in the hepatic vein. This is bedside test. We also will do for this patient specific investigations, uh, anti-nuclear antibody, anti-double stranded DNA, or rheumatology panel we will run. Rheumatoid factor also to rule out mixed connective tissue disease, anti-RNB, like this. Then it's general investigation, CBC, chemistry, RCRB, C3 and C4, like this.
Okay.
Sometimes if we cannot diagnose this Budd-Chiari syndrome by ultrasound may be difficult, so we can do angiography.
Okay. Suppose ultrasound confirmed I have Budd-Chiari syndrome. How to manage this Budd-Chiari syndrome?
This actually, if it is subacute and mild for 1 month like this, so possibly only anticoagulant can be the treatment in the form of unfractionated heparin, low molecular weight heparin, then oral, Nowake Bixibam 5 BID or like this, bolus 10 or 50 milligrams in BID. But if it was massive thrombosis, it can cause liver failure. But in this case, not liver failure. So at that time, possibly this will be managing with the liver. We will include multidisciplinary team for this case, including liver doctor, GI doctor like this, and the rheumatology also, to put the plan of management in such a case.
What if failed anticoagulation?
Hmm?
What if we have failed anticoagulation, failure of anticoagulation? What we can do next step? Because it's a common
I'm sorry.
practice in Budd-Chiari.
Sorry, in such a case, due to secondary antiphospholipid syndrome, this NOAC is not good, so we will use warfarin. If it warfarin fail, we can use filter, inferior vena cava filter. It is possibly better than anticoagulant.
But
We
why
use
inferior?
we
What
usually
else?
add aspirin with warfarin.
What else?
Other than inferior vena cava filter,
No, inferior vena cava filter, no, apart from inferior vena cava. What other treatments for Budd-Chiari syndrome?
you mean embolectomy, thrombectomy
Yeah,
from
one of the
the.
choice. Yes, go ahead. What
Mhm.
else?
I don't know if liver failure
Treatment of liver
develop,
failure
we will
complication.
do the liver transplant. Yes, if liver failure develop, we will remove the liver, do the liver transplantation.
Okay, what else?
I'm not sure.
Have you heard of intravascular thrombolytic therapy, TPA?
Yes, but this is should be in acute situation, not. This is already 1 month past now, so we
But
cannot
I
give
have,
this.
but I have also 6 month pain and fatigue. But usually in this last month, my pain is aggravated. So
So
the whole of the story was around 6 months, but the pain was for 1 month.
I think a window in heart about 6 hours, in neuro 4 hours. But no, I don't know the window for thrombolytic therapy in Budd-Chiari syndrome to give
Mhm.
thrombolytic therapy.
In
I
Achilles,
don't.
we can
Huh?
give. What other surgical therapy for Budd-Chiari? Because usually Budd-Chiari syndrome not respond to medical therapy most of the time.
Mm. So I don't know.
Stent placement, surgical embolectomy, one of the choice. Okay, liver transplantation, treatment of liver complication like varicose band ligation, and at the
What
end,
ligation?
Variceal band ligation, the complication of liver cirrhosis.
Portal hypertension. Yes.
Portal hypertension, yes. And final therapy, final treatment is liver transplantation.
Mm. Okay, but thrombolytic therapy can be given for after 1 month, okay?
It can be given for acute and subacute cases, yes, but usually given for acute cases. Yes,
Okay, okay.
yes. And as well as treatment of underlying pathology.
Yeah, thank you, Dr. Muhammad, and well done, Dr. Mahi. A nice discussion as well for the bad Kayari management approach. So let's start with a comment from Dr. Muhammad, then I will comment.
Okay, Dr. Muhi, thank you for this history and examination. Regarding the history, you were systematic, but you didn't cover the whole of the abdominal symptoms from upper GI to the lower GI, all should be included. Also the liver, abdominal distension, jaundice. You have to ask specifically for jaundice. You didn't ask for jaundice. And the pain you did well. It was systematic, covered well. And regarding the abortion, also you have to focus and to ask for family history and what was the reason behind the abortion, how was the investigation result by OB-GYN. And regarding the drug history, you have to be more specific and ask the questions directly, including the warfarin, aspirin, because I don't know, I am a patient. Because of this pain, I forget everything. So you have to be more specific in this point. Social history was good, and examination. Regarding the examination, I have abdominal pain. So the major system is involved is GIT system. So the main focus is inspection, palpation, percussion, and auscultation for GIT. This is first. Second, I give you a clue about the GIT, about the SLE and antiphospholipid. So the next system is the rheumatology. Joint examination, tender points, detailed joint examination, knee joint, lower joints, upper, and the oral inspection, as well as the general examination. Okay, so because I have shifting dullness in my abdomen, I have distended veins in skin over the belly. There was pitting edema even in my tummy and pitting edema in lower leg, but you didn't exam for this. And chest examination was uneventful. And that's all about. Regarding the differential diagnosis, 100% you are correct. You reached the diagnosis. But the main problem, I think it was in physical examination. That's all about, yes.
Yeah, thank you,
Good.
Dr. Muhammad.
You did well, yes. Thank you.
Thank you, Dr. Muhammad, for the comment. Please write your case scenario down in the chat box. Dr. Mahi will prepare himself. Oh, the opposite. Sorry, Dr. Mahi will write the scenario and Dr. Muhammad will prepare himself. I will comment starting from, let's start from the introduction itself and the name. You confirm the name by two names and the age, of course, and don't forget the name again. You mentioned two names in the scenario, Muna and Nadia. If you forget the name, you can easily say Madame or Sir for the male and the female. Easily. Don't bother yourself. Don't try to I remember the name. Oh my God, I forget to look at the paper. It's easily to say Madame and Sir and skip it. Okay, don't waste a time to remember. This is the first point regarding the data. The onset, cause, duration as an analysis of the complaint. In general, Dr. Mahi, really, you did great. You reached diagnosis, which I didn't do. But I was confused and misdirected by Dr. Muhammad. Let's start from the onset and course duration. You start the nature about the pain. You ask about the nature of the pain. But the previous, as Dr. Muhammad said, the previous history about the pain is very important. We have to ask about any previous attack, or any previous episode of the same presentation of this pain. Why? Because it might be acute on top of chronic. Simply, and you might miss the case if you thought about the acute only, or if you thought about the old and the chronic only. So we have to know it was different pain and now presented with another pain. I was confused when I heard about the meal related. So I thought about acute cholecystitis, something related to the fatty meal, but I didn't correlate with the clot or bad Kayari unless he mentioned the pain is increased with the jaundice, of course, with the SLE. But if you went through the abdominal pain from the start without knowing the nature of the pain exactly and how it was and how it become now, you will be missing the case. This is regarding the pain and the analysis of the complaint. I believe you analyzed the GI good, but as Dr. Muhammad said, you missed very important complaint, which is jaundice. You said yes, any change, but you can specify since you have some change in the GI at all, as general, I mean. So you can specify the pallor and jaundice and even scratch or scratching, a scratch mark or itchiness. All this will be related to the GI, liver, and bowel. Okay. And the most important thing, Dr. Muhi here, I appreciate you did the scenario as first practice with us, but you should be more speedy, more fast. Speed up your fluency and your question rate so you can catch more questions and answers and catch more finding by speeding up your questions. I felt like you are little or a kind of uh, like calm. Of course, yes, I need to be calm, but I also need to be fast because whenever you go with this rate of question, you will miss a lot of things. For example, in this patient, and it's very important to ask about the risk of HIV and hepatitis. Whenever you have hepatic disease or liver disease, you have to rule out the hepatitis. Here, you miss the whole HIV and risky habits, sharing needles, receiving blood transfusion, and partners, the casual relationships. Although you remember the female history, you analyze it well, the miscarriages, the periods. And for the period, I will ask Dr. Muhammad why this patient is having menorrhagia.
Dr. Bassem, one of the reasons was she's taking warfarin.
Okay, see, this is another missed point, the medication history. The medication history can give a clue for something hidden or something difficult to understand. Like here, menorrhagia, I don't know. I thought about thyroid, but thyroid was negative. So I was wondering why this patient is having menorrhagia. We don't know. Whenever you have bleeding tendency, you have to ask about any bleeding from any area and any blood thinner medication, like in this patient. Okay. Again, for the examination, as Dr. Muhammad said, you have to examine the main complaint in a focused way. The abdominal examination, you will spend maybe 2 or 3, not 3 minutes. Of course, you will not have the time to do a 3 minutes examination of the abdomen, but at least 2 minutes, starting by inspection, palpation, percussion, and auscultation. And the palpation, of course, will be superficial and deep. Any scar and superficial for any mass. Then the deep palpation for the all organs and the ascites as we do every time. Finally, the discussion was great. You were confident. You mentioned all investigation, and I like your way starting the investigation by systematic way. Started by general and specific and bedside and you mention something you can impress the examiner with the ultrasound, with the venography or sonography for the clots or the hepatic vein or thrombosis. So I prefer everyone to start in this way. You can add to the bedside test urine dipstick if the patient suspected to have kidney problem, because this is also systemic lupus. It might harm or it might affect the kidney. I think you missed totally the genitourinary system, right? You didn't ask about any water work problem or urine problem. So the only thing I need from you to speed up and to practice. Yes, you are confident, but still the speed of asking the question, the fluency need to be gained more with the practice. Is it clear, Dr. Muhi?
Yes, sir. I asked him about skin discoloration, any specific color, and I try to look it into the eye to localize the problem because he told me it is generalized pain. So until now, I don't know it is GI or liver.
Yes, you're
Uh,
right. By the way, I was also confused.
he
Ascites also.
confused me really.
Ah,
Yes,
the
I
cause, Dr. Mahi, the cause of this initially was generalized because of serositis from SLE.
okay. The previous, so
Yes,
it was like previous pain, and now the pain it changed. The nature of the pain being changed to acute colicky and severe with ascites. The
excellent.
triad of uh, bad Chiari here, the jaundice and the abdominal pain and ascites.
Right.
Yeah. So suppose also to mention the discomfort and abdominal distension. Supposed to be positive. Anyway, we are learning, and also as a surrogate, you are learning. Dr. Muhammad prepared the topic well about the investigation, the management. But again, the presentation was also vague. For me, it's still vague. I couldn't correlate. Maybe also the history was not that much optimum by Dr. Mahi, but we are learning, all of us. Every time we are getting more experienced and gaining more confidence. So no worry, Dr. Mahi, just practice and you will be in the proper way next time, inshallah. Okay? Any question, Dr. Mahi or Dr. Muhammad?
No, I have no question.
Okay, Dr. Mahi, please, before starting, try to either disconnect and reconnect or to check the mic because there is echo. I don't know, all of you hear this echo or only me?
Yes, I hear also. Yeah.
Yeah, so either to reconnect your
I
internet.
will, I will
Yes.
go out and come back.
Okay, waiting for you. I will try to have the comments from others and the questions until you join back. Any question or comment from others, please? Okay, let's hear, read the comments. And yes, pulses. I wrote pulses in comparison because of Raynaud's phenomena. Suppose Dr. Mahi to do this examination or to comment on, or at least offer pulses examination. I hope he joined back, Dr. Mahi, if you are back with us. Yes, Dr. Mahi. The pulse always, whenever you check the pulse in vascular patient or vasculitis patient, please try to ask or to comment. Pulse equality, is it equal? Is it any delay? Radio radial or radio femoral? Especially those with Raynaud or vasculitis features. Okay, it might be the Takayasu case, and you will miss diagnosis whenever you miss the pulse examination properly. Okay, so you have to examine the pulse here and there, and the nature and the volume. Okay, then thrombolytic, yes, Dr. Ibrahim, write it correctly. Tips also transhepatic intrajugular portosystemic shunting. Okay, anticoagulation warfarin. This is the cause of menorrhagia. Thank you. Your case, Dr. Muhammad, Mrs. Muna. How old, Dr. Mahi? presented with lethargy for 3 months.
40.
40 years. Okay. You can edit it, please, if you can. If not, I will copy it. Mrs. Muna, 40 years old, presented with lethargy. Okay. Lines in BCS. Anticoagulation, Batkayari, anticoagulation, thrombolytic, intravascular, thrombectomy, stent placement tips, port to caval shunt. By the way, it's not inferior vena cava filter, right? Because inferior
No,
vena cava,
it's
yeah,
yeah,
distal to the hepatic. So what the benefit?
no.
You need to put the filter below the liver or pre-hepatic, right?
Post liver, doctor. But carry is hepatic vein, means after the liver, between heart and liver.
So the clots coming from the bowel.
But carry maybe systemic or localized. If it's systemic antiphospholipid, as mentioned, occur directly inside the hepatic vein.
Hepatic. And how
Yeah.
the blood flow in the hepatic vein from downward
صح
upward,
حصل
right?
Usually the liver will become congested because of impaired drainage
تيبس حاجة
from liver
اسمها
to the heart.
abbreviation أي abbreviation for اللي هي شنط ديت فعلا بورتو سيستميك
Transhepatic.
شنط
Transhepatic.
مم.
Sorry, transjugular intrahepatic. Transjugular intrahepatic. Portosystemic shunting.
Yes, transjugular intrahepatic portal systemic shunt. Dr. Bassem, portal vein, this is the issue. Portal vein, liver, hepatic vein, and heart.
Okay.
Okay, so the problem is inside the hepatic vein in Batchiari, means between
Yes.
the liver and heart. So the space is closed already by thrombus or by anatomy, occasionally something by ring or some congenital malformation of hepatic vein makes Batchiari. This is called congenital Batchiari.
Yes.
So we have to make this space open in order to allow the liver flow or liver blood to be drained to the heart finally. But once we have impaired or blockage of hepatic vein, so all the hepatic or all the liver blood will remain inside the liver itself. So it will makes hepatomegaly and finally portal hypertension and the ascites.
Okay. So the placement of the filter in which vein?
This is called portocaval shunt. Means what?
Yes.
Caval, the branch of inferior vena cava finally once reached to the heart. Porto liver. So we have to make a bridge between the liver vein bypassing the hepatic vein to cross the inferior vena cava.
This is stent. You mean this is the stent? I'm talking about the
Shunt
filter.
process. No,
You
doctor.
got. Uh-huh.
The tips.
No. I'm not talking about tips at all. I'm talking about filter. He mentioned filter. I think.
IVC.
Yeah.
I think it
Inferior
is
vena cava
very
filter. Inferior vena cava filter in this scenario has no benefit. Why?
Yes. Yeah. Yeah.
Because
This is my point.
the problem is not inside the inferior vena cava.
Exactly.
The
So it's
problem in the hepatic
distal to
vein.
the problem. Exactly. So it's distal to the problem, which is in the liver. So what the benefit of the filter here? You got my point, Dr. Mahi. So I think it's not an option in this scenario.
No, IVC filter has no role in Batchiari.
Exactly. Because he mentioned it in the discussion.
Yes.
Okay.
I'm wrong, Chris.
Yes. The jargon here. Yes. Gut. Yeah. You
GI
can say gut, not GI. Gut doctor. Yes. Exactly. And it wasn't mentioned, so mention what it was written in the scenario. Don't say something different. If not written, as I said last week, I am one of the doctors here. No specify of the gut or the clinic, and don't specify your position. I am one of the doctor here. It's the most simple and easy way, and not to have a mistaken position or clinic. I am one of the doctors here, and proceed. Clear? Dr. Mohammed Musader, if you're ready for your scenario.
Yes, I am ready.
Okay, we can start now. Here you go.
Okay. Good evening, Mrs. Muna.
Good evening, doctor.
Okay, I'm Dr. Muhammad. I'm one of the doctor here in this hospital. Am I speaking to Mrs. Muna?
Yes, I am doctor.
Are you 40 years old age?
Yes.
Okay. Mrs. Muna, today we are going to discuss some point about your health condition and the reason for presenting to attending to hospital. And we can after that doing some physical examination on you. Is that okay with you?
Okay. Okay,
Okay.
doctor.
Okay. Would you tell me why did you come to the hospital? What was the reason behind attending to this hospital?
Actually, doctor, for about 3 months now, I'm feeling tired all the day, and I cannot cope for my daily life, and I cannot go to my work. All the time, I am feeling sick, feeling tired, sleepy all the time, like this.
What do you mean by tiredness?
I have no power. I have
No
no
problem. Okay.
activity.
Okay. I mean, there is no some arm or leg problem, weakness.
I have, yeah,
It's
I feel
general, all of the
my
body. All of the body, you are
yes,
feeling tired. Okay. Since when
yes,
it started?
3 months.
3 months. Okay. Do you think any progression recently or has been increased recently?
No, no,
No.
it is it.
And okay, any change between the day and the night?
No,
No. Okay.
all
What
the
factor?
time, all the time,
Huh?
all the time.
Okay, it was started suddenly or it was gradual?
Gradual, doctor.
Gradual. Okay. What factor make it better?
Nothing.
Nothing. What makes it worse?
I'm not sure.
You
It
are
is
not
worse
sure.
with time, day by day.
Mhm. Okay. What do you think else apart from, do you feel any raised temperature? Do you have
No,
fever?
I no,
No. Any night sweats?
no,
Recent change in weight?
no.
No. Any bumps or lumps in your body?
I'm not sure, doctor, but while I am seeing in the mirror, I see that in front of my neck, I think my neck become more, uh, more swollen.
Mhm. I'm sorry for that. Okay. We are doing what is best for you here. Do you feel your face color changed in comparison to the to previously?
This
Means
color?
more paler than before?
No, 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 no,
No color. Okay. Any weather changes? Preference to any way weather?
no,
Uh-huh. Any difficulty in swallowing?
no,
Mhm. Any abdominal or tummy pain?
no,
Nausea or vomiting?
no.
No. Do you feel you have changed some or have bowel motion changed recently? Lose motion or constipated more?
Usually, doctor, I usually open my bowel once daily, but recently, about 2 months now, I think every 2 days. It become every 2 days I open my bowel.
Mm. Okay. How about the stool consistency? I mean the content. Is there any blood with it or it's hard
No
stool?
blood.
No.
Hard, yeah, somewhat hard, yes, but no blood.
What about this lump in your neck? How it was? It's fully or covering all of the neck, or it's small size, partial in one side?
Yes, it's covering
Uh-huh.
all the
And it,
all the front, all the part. But doctor, I remove my gland in front of the neck before, but I'm not
okay.
sure why it become again this. I don't know this is a skin or anything.
Okay. Okay. Since when you have done this operation?
I remove this gland about 5 months, 5 years now.
5 years now. Do you take any medication for it?
No,
No.
No medication.
Okay. Mhm. Okay. How about urination? Water work. It is too much or not?
No, no.
No changes. So,
I am no,
any abdominal
nothing is.
belly pain? Any belly pain?
What?
Tummy pain?
Yes, I have
Uh,
some tummy pain, but more in the
more.
side of the tummy. Yes,
Where is it?
in the side of the tummy.
In the sides. Okay. Okay. Is there any relation with food? Any pain, tummy
No,
pain?
no,
No relation.
no.
Okay. How about the severity?
It it look like colic. It come
Colic.
about 4, 5 like this
Mm,
from 10.
mm. Okay. Do you feel you have dizzy or room spinning around you once you wake up from the chair?
No, I feel some headache also, doctor.
Headache.
I feel headache.
You feel headache.
Yes.
Okay. Let's go to the
I
last medical. Mhm.
recently, sorry, yes, yes, doctor.
Okay. You
Um,
have something to, okay.
this headache, I usually take painkiller for it, and I check my blood pressure recently in primary health care like this, and they told me about your blood pressure about 155 by 95 like this.
Okay. Since when this high blood pressure?
About 2 weeks back, but I
2 weeks.
don't care for this because I don't have raised blood pressure,
Okay.
and I have no family history blood pressure. Okay,
This headache is coming in episode or it's continuous all of the time?
just continuous, doctor. No
Continuous. Do you
specific
feel
time.
any sweating or any chest pain with it?
No, 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 no,
Okay. Okay. Do you feel your face is flushed during the attack?
no, 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 no,
No,
doctor.
surgery. Normal. Okay. Apart from high blood pressure, what medication you are taking for this blood pressure?
I'm not taking any medication.
You are not taking. Okay. What else do you have?
The doctor wanted to give me medication, but I refuse because I don't have hypertension.
Okay. What else you have? Do you have any history of heart failure or lung problem?
No, 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 doctor.
No, no lung problem. Any prior history of admission for any reason?
This surgery, doctor, for the
Apart
gland
from
5 years.
apart from the surgery, have you received any blood?
No,
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 any blood received. Okay. Any prior infection, Dr. Mahi?
no.
No. Okay.
Yes.
The surgery done for this, only this surgery you made, right?
Yeah.
Was
Surgery
there?
for this gland, yes.
Oh,
Thyroid gland, yes.
okay. Are you taking any medication? You mentioned you have not
No,
any,
no,
no. Even herbal medication, herbal medicine?
no,
No,
no, no.
no. Okay. Do you have any family history of this illness? Same illness you have?
Really, doctor, I am adopted.
Uh-huh. Adopted. Was your step parents complaining of any illness?
I am adopted. I don't know my father or my mother.
Okay. Any history of renal stone before?
I did not check anything, but I
Urine
don't
check.
know this pain is my side of my tummy. Maybe this is related. I don't know.
Have you done any investigation for this pain?
No, no, no. It come
Okay.
only 2 or 3 times, and I drink some water, and I think it is relief like this.
Okay. How's your mood?
My mood is low, doctor, because I don't know why I am feeling weak all the time like this. I
Mhm.
cannot go to my job.
I'm sorry for this, Mrs. Mona. I'm doing the best for you regarding this issue. I have to, can I ask some private question?
Yes, yes, doctor.
Okay. Do you smoke?
No,
Do you drink alcohol?
Occasionally, doctor.
Okay. What about your menses periods? Normal, regular?
Yes, it is normal, doctor.
Do you take any pills, contraceptive pills?
No, 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 no.
How
I
many
don't have
pills?
partner, doctor. I don't have partner, doctor.
Ah, you are single. Okay. Okay. Sorry to ask this question. Do you take any illicit substances?
No, 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 doctor.
Okay. Well, okay. You don't feel any difficulty in breathing or chest pain?
No,
Okay. No arm numbness, or you feel some tingling or pins and needle sensation in your legs?
no.
Okay. You can control over your bladder or bowel?
My bowel, as I told you, I was opening it once per day. Now become more than 2 days to open my bowel.
Mhm.
Hard, but nothing more. No blood, no slim.
Okay. Mm, okay.
Yes.
Can I examine you, Mrs. Muna?
Okay, yes,
Okay.
exam.
Okay. Hand examination. Do you have
Yes, pulse is 80 per minute regular, equal in both sides.
what about blood pressure? Orthostasis?
Blood pressure. Blood pressure is 160 by 100.
No orthostatic change.
No.
What about hand pallor,
Hap-
hyperpigmentation?
No, 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 normal.
No skin change. No nail
No,
change. Okay. What about
no,
skin? Dry, coarse skin?
no.
No such
Skin
skin.
is okay.
Skin is okay. Okay. Face exam, pallor, jaundice,
No pallor, no joints.
any central cyanosis?
Yes, thyroid. What?
Central cyanosis.
Thyroid. No cyanosis, no cyanosis.
Mm, okay. Neck exam, thyroid,
Yes. Yes, there is a scar of the old operation, and there is a swelling diffuse in the
tender.
thyroid gland by level.
Uh-huh. Not tender.
No, it is not. It is not tender. Yes, but it
Okay,
is
JVP.
no raised, not raised.
Okay, this bump in your, or a lump in your neck moves with swallowing?
Hmm?
Moves with the swallowing foods?
Well,
The thyroid
should
lump?
be no. It is thyroid. Yes, it is thyroid.
It is
It is
thyroid,
thyroid
okay.
gland.
Okay,
Two
abdominal,
minutes
chest
left.
exam. Okay, chest exam,
It is
cardiac sounds.
clear. It is
Okay,
no
okay,
murmur, no gallop,
okay.
clear chest
Bowel.
bilateral.
Mm-hmm. Okay. Tummy abdominal examination.
No organomegaly.
No tenderness, no organomegaly, even flank
Yes.
tenderness.
No, what? Tenderness where?
Flank, both loin.
Mm,
You
no, no,
can
doctor. No, it is
mm,
only Kolki bean. It come and go only.
sweating everywhere, anywhere.
No sweating.
No
No
sweating.
sweating.
Okay. Lower limb exam.
No edema.
No edema at all.
Pulses, peripheral pulses is okay.
Um, okay. Cardiac and chest was clear, free of sounds.
Yes. Clear, yes.
Okay. Okay. Mhm. Okay. And you are conscious, oriented to time,
Yes,
place,
I'm conscious.
person.
All the time conscious oriented, doctor.
Mhm. Capillary refill is normal.
Yes.
Normal. Any change in
Oh.
tone, power, reflex?
No, it is okay. No, doctor.
Okay.
What is going on, doctor, with me?
Mrs. Muna, according to your history, you have 3 months back presented with tiredness all of the time. You
Yes.
have done surgical operation for thyroid previously. You also
Mhm.
concomitantly complaining of bilateral loin pain, both sides abdominal pain, and
Yes.
occasionally also has high blood pressure. Uh,
It is.
we
Yes.
can suspect, we might suspect there is a problem with your glands in body. It's called man. But we
Yes,
have
yes.
to take all the history of prior family history as part because you are adopted. We have to get back to your original family history about the same pathology because it's an inherited disorder. Okay, the chance of
Yes.
inheritance about 50%. Yes.
Okay. So,
Okay.
doctor, what you will do with me now?
Okay, we have to do some basic investigation, including the thyroid function test, CBC, and serum electrolytes like serum sodium, serum calcium, and
Okay, this is examiner question. Sorry,
The
he's addressing concerns. Okay, I think time is up, Dr. Muhammad. We can start the examiner question now.
this ambition now.
yes,
Okay.
yes.
Okay,
Do you
Okay.
have
start
any
with.
more concern, Doctor Miss Muna?
Thank you. Thank you.
Okay,
So, what is the positive finding in this case, Dr. Muhammad?
okay. The main positive finding was high blood pressure, but during the examination was normal, episodic
No, no, it
hypertension.
is one. It is 160 by 100. I told you during the examination, it was 160 by 100.
Ah, okay, okay. I hear that it was 130. I'm sorry. Okay, so you have hypertension, you have
Yes,
thyroid
yes,
hypertension, thyroid mass,
yes,
uh,
thyroid med.
abdominal pain bilaterally, non-specific
Yes,
abdominal pain, low mood, depression. Uh, that
tiredness.
yes,
Yes,
all this goes with
tiredness,
Mann syndrome. Yes,
which
Men type
be
2,
one,
type 2,
one
type
or one
2. No, men type 2 because of
type
pheochromocytoma.
2.
Yes.
Why pheochromocytoma, doctor? What is the evidence of pheochromocytoma in this case?
The evidence was high blood
No.
pressure. This is first.
Yes.
Flank pain.
Flank pain is
The
due to what? Why flank pain? Why patient has flank
because the pheochromocytoma is a tumor in belly by itself.
pain? No.
Uh, Abdominal tumor can compress on the surrounding structures.
Mm.
Yes.
Okay. Okay.
Yes.
What else? What else? Pheochromocytoma. What else?
What? This is the first. The second is the thyroid disorder. Both hyper
Patient
and
already,
hyper
patient already removed the thyroid 5 years back.
because of hypothyroidism, iatrogenic hypothyroidism,
Hypothyroidism.
iatrogenic hypothyroidism. Yes, makes
What
fatigue.
is the what is the evidence of hypothyroidism here? Patient has no evidence of hypothyroid function. There is no bradycardia. There is no skin, dry skin, thick dry skin. No
Mm,
buffy face like this. Thyroxine medication. So despite this, there is no any evidence of hypothyroidism. So
yes, no hypothyroidism. Yes, maybe related to the multiple endocrine
this,
neoplasm. Yes,
uh, what this mass you when you examine the thyroid gland, what you feel in your hand? What you feel? It is like the patient said to
the
you, it is
consistency,
folding of the or it is a
the
gland.
consistency will be firm, firm inconsistency,
Hmm?
firm
Yes,
inconsistency.
firm inconsistent. It
Okay,
is going
hard, firm
with
incons
thyroid or skin fold, like the patient said.
Firm inconsistency is not a feature of hypothyroidism or it's a feature of malignancy.
Yes, it is malignancy, firm thyroid gland malignancy. But already patient, she told you, I removed the thyroid gland 5 years back. So how
Maybe
you
recurrence,
explain it?
recurrence of the tumor by
Recurrence.
itself.
Yes,
Yes,
recurrence of the tumor. Yes, recurrence of the tumor.
recurrence of the tumor. Yes,
Yes.
but
What is the cause of headache in this case and the lethargy?
cause of what?
Feeling Mm. Why patient feel weak all the time, tired, loss of
Okay,
activity,
could be related to
hard
the
motion,
mm, okay
hard motion?
hypercalcemia.
Yes, hypercalcemia due to hyperparathyroidism. Some?
Yes,
Yes.
hyperparathyroidism induced hypercalcemia.
Yes.
By itself, malignancy is the catabolic state. The patient already feel tired, and
Yes. Yes.
okay,
If I,
we
if I, if I give you chance to examine something else, what you will go to examine? If I give you 30 seconds to go to examine the patient to look for one thing, what you will look to?
lymph node exam.
Yes, very good. Lymph node. Yes, lymph node in the supraclavicular
I
or
forgot.
yes, yes.
Yes.
Okay. How you will investigate this case? How you will investigate this case?
Okay, the investigation usually start with basic investigation, includes CBC, renal function test, thyroid function test,
Yes, yes.
and liver function
Specific?
test.
Yes.
Bedside investigation like ECG, abdominal ultrasound,
You if you do
thyroid,
thyroid function test, what you will found? It is T3, T4. What you will found it?
usually it's euthyroid.
Normal, yes, yes. So how you will investigate this gland, thyroid gland? What you will do for it?
The best investigation is calcitonin hormone.
Yes, calcitonin is for monitoring. But now you wanted to see this bulky mass. How you will assess it?
Best investigation is ultrasound guided thyroid biopsy.
Biopsy.
Yes.
Before biopsy, what you will do? Because
Mhm.
uh, you cannot go direct to the biopsy before you see some
CT of neck.
ultrasound, so ultrasound, and you will
Ultrasound
do
first, CT of neck
thyroid
to see
scan,
the.
thyroid scan to see it is hot or cold nodule or
Uh-huh.
active. Yeah, okay. Then
Okay.
you will go to biopsy if you want.
Yes.
Uh, and for the parathyroid, how you will what you will how you investigate, what you will do for it,
Okay.
laboratory,
Serum
laboratory,
parathyroid,
parathyroid, yes,
serum calcium, serum
and
phosphate, serum ALP, urine calcium, and
enough
parathyroid
for this.
ultrasound.
Yes. You will find that calcium high and parathyroid hormone is high. Okay, okay, okay. So, for this case, Dr. Muhammad, how you will manage this case? What you will do for her?
Management usually it's according to the gland and pathology correction. Regarding the abdominal pain, if it's hypercalcemia induced renal stone, we have to give pain medication, excessive hydration, and diuretic, bisphosphonate at the end if still not responding. If it's
Yes.
medullary thyroid cancer, or for pheochromocytoma, this is for the stone, hypercalcemia by parathyroid. Second, for pheochromocytoma, pheochromocytoma needs confirmation
Need what?
by, yes, urine metanephrine and serum
Mm.
metanephrine. And
Yes.
once it's high, we have to do abdominal scanning, abdominal CT scan to see if it's primary pheochromocytoma or secondary paraganglioma. Uh, if it's primary, the only treatment for pheochromocytoma is surgery, but we have to prepare the patient by giving alpha blocker and beta blocker concurrently. The beta blocker, alpha blocker given 2 weeks prior to operation, beta blocker given 3 days before the operation, then surgical resection, then continue with the alpha blocker alone. Uh, this is for pheochromocytoma treatment. And for thyroid, the only treatment for MTC, medullary thyroid cancer, is the resection, as well as continuous follow-up of serum calcitonin and giving the
Yes. So you will
levothyroxine
do.
in low
So
dose.
you will do. Yes. So you will do radical surgery for the three glands. Is that right?
Yes, we have to resect all
And
these glands.
yes. Okay. Okay. Then what next step after you do radical surgery for the three
Genetic
glands? What you will
genetic counseling, genetic testing to
genetic
search for
testing?
the
Yes.
menin gene mutation. and
1 to 8.
family counseling. We have to get back to the story of the family. All of the members should be screened with this investigation, at least with abdominal and neck ultrasound. And this is about, yes.
For this woman, after
For
this
this
genetic
woman,
testing for the other patient,
yes, we
what you
have
will do
to,
for her?
yes, we have to also advise the woman
Uh,
to avoid pregnancy,
because
at least for
recurrence, because she has recurrence, how you will follow up? You will follow up or no need?
the follow-up made. Yes, definitely. We need follow-up.
By
We need
by what?
we
You
need
will
to
follow up
follow
with what?
the serum calcitonin, blood pressure measurement,
Yes.
and
Calcitonin and what else? Yeah.
blood pressure measurement, serum calcitonin, serum calcium, serum PTH.
Okay. Thank you, Dr. Mohammed. Thank you.
Welcome, doctor.
Dr.
Perfect.
Basim.
Yes, amazing discussion, really, Dr. Mahi. Thank you for refreshment of this
Thank you.
all informations. And by the way, all of us has good knowledge, and we know how to answer in information wise. But what to answer, we know, but how to answer, this is the most important. So be systematic always, as Dr. Muhammad do or did. He tried to make it systematic in his answer, and always start with counseling about the disease. If he asks you how to manage, start by counseling. Counsel about the condition, the medication, and the management plan, multidisciplinary team approach, and don't forget the future family. Here, it's very important about counseling for babies, or if she's planning for pregnancy, or if she's planning for having kids, because it's important to prevent this gene to be transferred to the kids. She's adopted, so forget about her family. Whosoever the family, she's adopted now. We don't know. You want to diagnose her, and you want to prevent further diseased generation. How? By referring her to the genetic counseling to have a safe baby. This is regarding the management. I start from the end. Uh, the discussion was okay. I will not comment about the topic because it's clear meant to A. And always Dr. Muhammad mentioned what type. You said one meant two. There is two types under two. So it's 2A, either 2A or
Yeah.
2B. You have to specify.
Yes, yes, yes.
So it's 2B because 2A, sorry, because of fucocytoma along with parathyroid. The thyroid here was non-functioning, so whatever the thyroid, it will not be functioning one, neither hyper nor hypo. But if you want to say, as you said, because of the removal of the gland, maybe the patient will have hypothyroidism. If they did or she did total thyroidectomy, but they might remove only the cancer itself or uh, the nodule or whatever. So it might be spared. I mean the function. So we'll forget about this. Unless the patient will have symptomatic hypo or hyperthyroidism, you can mention according to the scenario. But in this scenario, supposed to talk about pheochromocytoma and parathyroid. So as you discover in the history, the hypertension, I don't know how you missed, you hear it wrong, but it was hyper. I heard it 160. So hypertension, sweating, headaches, episodes, and sweating tremors. I don't know if you ask about tremors either in the history or in the examination. You have to do it to do it. Okay.
Okay.
Yeah, the pulse. This is in the examination. Let's start from the history. I think the history was okay. It was disorganized, kind of disorganized, but maybe because this is a first practice video, so you need to train more how to get faster in the history and systematic one, organized and systematic analysis of the complaint. And the good thing here, you ask what the meaning of lethargy. Is it weakness, muscle, joint, or difficult to get from chair? What you mean by lethargy? Is it something you can please explain more to me or for me what you mean by lethargy? Then go ahead through the onset, course, duration, the previous history, and previous medical history is very important here. You can know a lot of finding by the previous surgical or previous medical. Previous surgical, she will tell you thyroid, so you will suspect something related to the endocrine. Endocrine, you will analyze more about the endocrine, the weather. You will not find anything for the thyroid, so you will suspect other glands, pituitary, pancreatic. You rule out the pituitary, you rule out the pancreatic, so you have now parathyroid and suprarenal. Suprarenal fucocytoma, parathyroid adenoma for hypercalcemia, and the signs and symptoms of hypercalcemia. You have to specify everyone. Headache, mood, as you did. I think you cover the mood, the sleep. As I said, always SMS, sleep, mood, stress, sleep, mood, stress. This is for the CNS manifestation of hypercalcemia and the fucocytoma, as you did, headache and tremors and sweating and hypertension. Apart from this, related to this case, yes, female history is important to rule out any related period or OCB, as you did exactly. I think this is in the history. We'll go now to the examination. Again, the tremors you missed, I don't know, you have to do and make it as a habit if you have something related. And the previous case as well, it was important to check for flapping tremors. Here you will have the fine tremors. No need, it will not be flapping, it will be fine tremors. Sweating, as you did or you said as examination, and the blood pressure sitting, standing, the gland, the scar, and the head. For the headache, I mean, you can offer fundoscopy if the patient have hypertensive, so you suspect hypertensive retinopathy. Going down to the neck, examine the thyroid quickly. The steps of examination: inspection, palpation. Especially if there is scar, you have to point to the scar. I guess you cannot do the examination for the kidney or suprarenal. So you just show the exam that I picked up the most important finding in this pheochromocytoma finding, in, as I mentioned, the hypertension, the sweating, and the headache as attacks or episodes. The discussion again was, I think, clear for all of us. The recurrence, the monitoring, the investigation, and for the imaging management plan. But please, everyone, please to be systematic. It's 4 minutes only or 5 minutes. He will ask you. So no time to talk about the doses. I was wondering, I think Dr. Mahi, you mentioned doses of warfarin, apixaban. They will not go through these details. Here also, if you want to mention alpha blocker, that's it. Don't mention names. They need from you to know what your line of management, not specified and not detailed management. So whenever you reach to the pharmacological, mention names only. They want to know if you are putting good approach to the management, and don't give detailed management by yourself. I will call multidisciplinary team approach, or I will follow multidisciplinary team approach. They will manage this patient with me. Whatever the team, you mention them, and that's again the counseling about the disease, counseling about the complication is very important. Some teams here supportive, social, and so on. I think also family genetic and family issue is very important here in the counseling, genetic team as well. Any question from Dr. Muhammad, Dr. Mahi?
Thank you, sir. Thank you.
Thank you, Dr. Bastim.
Really, it's amazing to be starting, because always the candidates or the doctors stress to start. But whenever you overcome the beginning of a practice, you will be practicing every day and at least every other day, and you will like to practice. This is the problem only at the beginning, but whenever you face it and you already overcome it, you will do it, inshallah, in regular basis. I will not say every day or every other day, but at least this is the start. Both of you started as long this first time, I guess, but you did great, both of you. This is the approach, the history taking, the examination. Need only to be practicing frequently to be more organized and to be more professional. Otherwise, you did great, both of you.
Thank you, sir.
Most welcome. We will open the discussion. Anyone has comment? Sorry? Sorry, Dr. Sally, if you are talking to us, the sound is not clear. Dr. Sally? Okay, anyone else has comment or question? Let's read the comments quickly. Starting from, yes, type 2, yes, as I asked, type 2A or B, you have to mention. Flank pain, of course, renal stone, you have to analyze it and to ask for any passing stone, any blood, any urine change, the amount, the color, any blood. All these questions are important. Thyroid tumor, yes, of course. Medullary thyroid cancer, exactly. And the monitoring is calcitonin, and it will not be function. Bone profile. If you want to save your time in the answer of what investigation you want to do for parathyroid, it's bone profile. What are they? It's calcium, parathyroid, and phosphate, vitamin D. So easily to mention if you are in hurry. But if you are not in hurry, be smart always. If you know something and you want to give him in details, give the examiner the details, but not too much detailed. Like in this question, bone profile, or you, if you are in hurry and the time is near to finish, you can say bone profile, or you can mention all of them if you have time to mention all of them. Like phosphate, as I said, calcium, phosphate, parathyroid level, and vitamin D level. And other electrolyte, of course. Don't mention only those electrolyte. Sweating should be there. Yes, I think he said yes, there is sweating. Right, Dr. Mahi? Also, there is figure by Dr. Ibrahim. Thank you, Dr. Ibrahim, for your always support and commenting. This figure is nice. We can share it to the group. I will share it. Or if you can, if you have, you can share it to the WhatsApp group. Yeah, I think it's clear. We all of us know the three Bs for min one. Also 2A, it will be two Ps only. You will remove the pituitary and pancreas. You will leave only parathyroid and pheochromocytoma plus medullary thyroid cancer. Here is min gene, sorry. And for the min 2, it will be RIT gene. The min to be, of course, pheochromocytoma and marfanate features. Yes, you have to know all. I think this is basic. All of us knows it. Know it. Calcitonin as a marker. Yes, exactly. Okay. Any question or any comment from anyone, please? Dr. Mahi and Dr. Serde Muhammad.
No, I have no comment. Thank you, Dr. Bassam, for
Most
all
welcome,
the
Dr. Muhammad.
clarification.
Sorry, I don't. I wanted to ask one question.
Uh-huh.
For pheochromocytoma, I read only one time that it may be episodic or sustained hypertension. But for other
Yes.
symptoms, tremors, sweating, and episodic headache, flushing, this is also can be episodic or sustained,
Yes. No,
or
I
can
think episodic, the headache and the tremors, sweating, and anxiety also, it might
it is
be episodic. But blood pressure, of course, it will be sustained.
sustained?
Dr.
Okay.
Mahi,
Yes, sir.
the episode, all of the episode, sweating, headache, flushing, blood pressure is called adrenergic surge.
Mm-hmm.
Okay,
Yes.
comes in episodes, but the
Yes.
blood pressure finally will stay up unless you
Exactly.
have surgical operation done
Yes.
for you.
Yes.
And it is benign or malignant
It's
tumor?
malignancy, malignant.
10%. You remember rule of 10? 10%
10%.
is malignant, 10% is bilateral, 10% familial.
So 90% of cases are benign tumor. Is
Yes,
that
it's
right?
not malignant. Yeah, it's benign.
And the parathyroid also it is adenoma benign tumor.
Adenoma, yes. Adenoma is, yes, benign. The only cancer here is medullary of the thyroid.
Mm.
Also
For
added,
hypercalcemia.
yeah.
Sorry. Yes, sir. Yes. What
Yeah,
you
yeah.
want to
A
say?
few chromocytome also 10% recurrence. So 10% rule of 10 recurrence, 10% bilateral, 10% cancerous. Okay, your question?
hypercalcemia must be all the symptoms of hypercalcemia
No,
present
no,
يعني must
not
be
must all. No, no, no. You might find
يعني
most of
مثلا
them, but not
اديت
necessary to
example
find. But you have to screen all of them. Started
yes I
from
have
the
to
brain,
screen
yeah, screen all of them. Headache, the psychological problem or mood change, for the abdominal pain, bone pain, polyuria, flank pain, renal stone, constipation.
يعني
Yes,
if there is, if there is no polyuria if there is no polyuria still hypercalcemia is in the diagnosis
yes,
no
yes,
polyuria in this as example no polyuria only hard motion
yes,
hypertension
yes,
epigastric pain so it is still hypercalcemia.
exactly. It's not necessary to
Okay.
find all of them, but you have to screen all of them.
Yes, sir. Okay, sir. Okay.
Okay. Yes,
Thank you, sir.
it's
Thank
easy
you
to
for
do it, and with the training, you will do it by heart. 1, 2, 3, 4, 5. You will finish it. Then you will go to the
maybe
next step,
session five.
and so on.
Session five is phobia for me, really.
No, no,
والله.
no, 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 no. Be
والله
please.
phobia.
You have to be
والله بابا.
much confident because it has 28 times 2 marks. So once you pass, I think you can pass the exam, hopefully. So don't make it like hobby. You have to like it or to love it. If you have any phobia for anything, it will be difficult to face it. So the best thing is to practice it. Okay.
Okay, sir.
Yes. Any question else? Any question from anyone? Okay. Thank you. I enjoyed this session with Dr. Muhammad, Dr. Mahi. Inshallah, tomorrow with the communication day. Good luck and good night. Assalamu alaikum wa rahmatullahi wa barakatuh, everyone.